And now talking about the solution. So how do you think we can improve the problem of the training of the primary care physicians? I think that's something that's probably going to be really hard to change.
Yeah, well, so for instance, currently, our organization, we are the preceptors for the TMH, which is our local hospital primary care residency program. People come from all over the world for this particular program. So how did that happen? Well, we were asked to come over for over a decade in terms to help foster their knowledge base around assessment and care for musculoskeletal conditions. Over time, that morphed into a full-blown program. And so my suggestion is this: we have got to somehow improve the education system around musculoskeletal assessment and care for primary care. That's one solution. And I think this probably from many of the podcasts you've done, but when we know we're doing something wrong in medicine, it still takes 40 years before it gets phased out. And when we know that something's actually correct and all the disciplines agree, it still takes 17 years before it becomes mainstream medicine, right? So it takes time, and it will continue to take time, but getting to the primary care group and formally training them how to better triage musculoskeletal, that's solution number one. Solution number two, and this could sound a little bit self-serving, but I've been at this for 30 some years. Solution number two is giving conservative care clinicians within the university systems a very good exposure to mechanical diagnosis and therapy, which is a cause and effect evaluation, right? It's a much misunderstood and misaligned approach. But if you look at the literature, the intertester reliability of the approach from an assessment perspective is beyond reproach. So that fits all the university's bills. Now, the validity in other words, the treatment process, and I'll get into this in a minute, the literature is up and down. Some literature is supportive, some not. And it's as to be expected. So if you're asking for the next piece, it's to get the universities, the trainers of these chiropractors and physical therapists, to formally educate around mechanical diagnosis and therapy. The reason is because of the intertester reliability and its ability to use a cause and effect analysis to make decisions around the best care pathway, rather than the old anatomical models that seem to currently drive the decision making. Then the third part is it's not good enough to just train clinicians. You've got to develop standards and quality assurance programs that are associated with the patient's process, starting at the first assessment right through to discharge. And the reason is that if you don't have a standardization and a quality assurance program around training for conservative care clinicians, you can't guarantee the outcome. So you've got to consistently try to get people to the right clinicians. And then from there, you got to get those clinicians to get to the proper decision-making outcomes. Should these patients self-care? And if so, how? Should these patients be managed conservatively? And if so, how? Or should they be escalated into injection or surgical care? And if so, to whom and for what reason? And all of those parts have to be fixed. And I think they can be fixed if you can train primary care and you can train conservative care clinicians to better understand A, derangements, those rapidly reversible conditions, B, the prevalence of spinal-related peripheral joint complaints, and then do that to a standard and then quality assured around that standard with every patient. That's how you fix it. And that's actually what our organization does.